In this video, we're going to be looking at pharmacodynamics, and in particular, we're going to be looking at individual variability and the reasons for individual variability. So here are the learning outcomes that we'll be looking at throughout this video. So what we will be looking at in this slide here is how a dose response can not be linear. So in this case, we've got the dose and there is an expected response, but there's a lot of variability that happens between dose and the outcome. So the first thing we'll look at is formulation. So tablets have to be within certain parameters, but those parameters are within 10%. So there's some variation within, or it's plus or minus 10%. So there's variation within the dose that the person will actually receive in every single tablet. The other thing that provides a level of variation is the use of generic medicines. Now, generic medicines are not identical, but they're very similar. But there is a level of difference between one generic formulation and another generic formulation, which will provide a level of variation in the eventual outcome. The next point of variation is adherence. So, does the patient take their medication as expected? Do they accidentally forget? Does life become too busy? Do they not like this particular medication? Does it have side effects? Does it taste funny? These are all things that can influence whether somebody adheres or is compliant or concordant with their medication. There are genetic and phenotypic variations in the way drugs are dealt with by every single individual, and that will also provide a level of variability in the final outcome. And then there are the pharmacodynamic variations that you see as well. So again, genotype and phenotypic variation in the outcome will be different in every single patient. And then another one, and now sometimes this is included and sometimes it's not, is the link between the parameter that you're trying to control and the final outcome. So for example, you're trying to lower somebody's blood pressure. What is its relationship to preventing somebody having a stroke? So there is variability in that outcome because there are other parameters that are involved. There is not just blood pressure. And so you add all this variability together and you end up with a much bigger total variability in dose. So that, and this variation is plus or minus as well. So there's a lot of variability for a single dose and comparing it to hundreds of patients that you might end up treating with that particular dose of that particular medication. So areas that you can actually try and rectify and dose individualized for the patient. There are a number of points on this curve where you can actually start to minimize and make adjustments. So one of those is the plasma concentration. Now, you can take a blood level and find out how much drug is actually in the system and therefore make some dose adjustments to get closer to your response or your expected response. Now, it could be plasma concentration, it could be the Cmax of that drug, it could be the Cmin of that drug, it could be area under the curve, it could be even salivary concentration rather than plasma concentration. So those are all different kind of points where you could actually monitor how the dose is related to what actually the patient sees as far as concentration goes. The other way you can monitor it is actually have a look at a biological parameter like blood pressure or blood glucose or HbA1c, again, another measure of glucose exposure. And so that can be your titrating point. And then that will influence what the final outcome is. So I've already talked about genotypic and phenotypic variation. So genotypic being to do with variations within the gene and how they're expressed. Phenotypic can be alterations in the way that genotype is expressed based on environmental factors that might increase or decrease the response. Now, it's also possible within those genotypic and phenotypic responses to have a hyperreactive response, so a greater in magnitude response compared to the general population, or a hyporeactive response, so less than expected from the general population. Another point of variation that you might see is tolerance. Now, this occurs as during drug exposure. And so the longer the person is taking the medication, the less effect that you might actually see, so a smaller response. And so you see this with the use of benzodiazepines. This is a sleeping tablet, and taken for a period of up to 2 months, the effect slowly kind of diminishes over time. You also see a similar effect with opioids. In this case, what happens to maintain the analgesic effect, larger doses are required. So you may see the term an opioid naive patient. So a patient that hasn't been dosed with an opioid will receive a different dose of opioid to somebody who has already been exposed to opioids because of this idea of tolerance. Another term that you might bump into is the term tachyphylaxis. So this is rapid desensitization or rapid formation of tolerance. And you might see this with the use of nitroglycerin. So nitroglycerin is used, it's often used sublingually to treat angina, so that heart pain with exertion. Now, if that is used too frequently, or in some cases it's available as a patch, if the patch is not taken off and given an 8-hour rest period, the patient will actually develop tolerance to the medication and it will stop working. It'll stop preventing and relieving those symptoms of angina. The other thing that happens with tolerance is that there is physical dependence that develops with that. And what this means is that the body makes adjustments to its own physiology, the ligands that it makes, the endogenous ligands that it releases. And what happens is that if you suddenly take this drug away, then the patient will experience withdrawal symptoms. And so what's happening here is the body has adapted its own physiology, its own homeostatic mechanisms to expect and to work with the presence of the drug. And when the drug is taken away, it needs to now readapt to the new scenario where the drug is not present. And this takes time. It doesn't happen immediately. And so between that adaptive readaptation to the new scenario, there are withdrawal symptoms. So in the case of benzodiazepines, if you stop taking benzodiazepines rapidly, then you'll end up with insomnia again, because the body has got used to the benzodiazepine being there and it's part of the sleep process now. So let's have a look at some of those mechanisms by which variation can be achieved. So the first one that we'll look at is alteration of drug concentration at the receptor itself. And there are a number of mechanisms by which this can be achieved. The first one is the metabolism of the drug can change. So if it's increased, like in the case of carbamazepine, then you will see a decrease in the exposure of the receptor to the drug. Nitroglycerin is the reverse. So it needs to be activated by that enzyme. And when that starts to fail, then you don't see as much effect of the nitroglycerin. You can also see active efflux of the drug with proteins like PGP, which is P-glycoprotein, which is a multi-drug effluxor protein, which will actually take drug and reduce its concentration as it pumps it away from the active site. The second mechanism that you might see is physiological adaptive changes to the presence of particularly antagonists. So in this case, we've got a beta blocker here, or a beta antagonist, which blocks the receptor from functioning. And one of the mechanisms of adaptation would be to increase the amount of ligand that is present to try and overcome the presence of the beta blocker. And so you might see some adaptive or tolerance developing to the presence of that drug. A third way of seeing variation is changes in receptor function or expression. And so that first point there is that you can see changes in receptor function. And one way of doing this is by phosphorylation. So this is done by an enzyme called a kinase. And so this can actually change the way the receptor interacts with other proteins. So the normal interaction might be blocked because the phosphorylation site prevents that interaction. But you might get other proteins that prefer the phosphorylated receptor for interaction. The second point there is you can actually have a loss of receptors. So the cell can actually take receptors off the membrane, and this changes the sensitivity of that cell to the drug or the endogenous ligand in future. And finally, it might be a downstream change or a distal change. So it might be a loss in the G protein coupled receptor, or the G protein itself is being lost. And that is one mechanism for changing the downstream response. Or you could have homeostatic rectification that you might see when you're using blood pressure lowering drugs. So if you lower the blood pressure, the body detects the change in blood pressure drop and says, oh, actually we need to adapt for that, I'll increase heart rate, or something like that. So if we have a look, and we're just going to unpack a secondary messenger pathway amplification, and really the main point of this slide is to look at how many ways the signal can be amplified by a single drug interaction with its receptor. So in this case, the drug interacts with the G protein coupled receptor, it activates the G protein itself, and it can activate lots of G proteins at this point. So 100-fold amplification at this point. And then it activates an adenylate cyclase, which then goes and makes lots of cyclic AMP, thousands of molecules of cyclic AMP. So now you have further amplification of that single drug interaction. Cyclic AMP goes and does its thing, and you can get activation of a kinase, protein kinase A, which can go and phosphorylate lots of other proteins and enzymes in the cell and change their activity. And so you can get further amplification of the signal via this mechanism as well. And so if you deactivate one of those G proteins or take it out of the picture or degrade one of the enzymes, then you're actually going to start modifying what the end result is going to look like. So let's have a look at some of the measures that are used to compare drugs with each other and also to explore the idea of drug safety. So just having a look at this curve here, we're looking at the percentage of people that respond to treatment on the y-axis, and we're looking at the dose on the x-axis. And we've got a few curves here. So the first one here is the therapeutic effect. So these are the number of people that respond. So here's the dose at which people start to respond. And then up here is the dose at which everybody has responded. And at 50%, this is the dose at which 50% of the people respond. We also have another curve here, which is the toxic effect. So this is the response of people to the toxicity or an early sign of toxicity for this drug. So you can see again that there is a threshold dose that people start to experience the toxic effects, and there is a maximum dose where everybody experiences that toxic effect. So as for effective dose, you can also get a toxic dose at 50%. And if you keep pushing the dose higher, then you might get the lethality or the mortality rate starting to rise because the drug itself is now starting to cause death in patients or in animals. And so you'll see a couple of variations of the therapeutic index. One is the original one, which was the lethal dose of the drug over the effective dose of the drug. And so the closer that is to 1, the more dangerous the drug is. And the higher that ratio is, so hopefully greater than 10 is the safest one. But there are drugs that have therapeutic indexes that are closer to 2, but that's probably more to this index rather than the lethal dose. And so in this index here, and you need to be careful which one is being referred to, you might be referring to the toxic dose compared to the effective dose. So let's have a focus a little bit further on the toxic versus the therapeutic effect. So we can actually have a look and define the therapeutic range or therapeutic window for the use of a drug. And so we can create this by saying, well, what's the minimum dose that people respond to? What's the maximum dose that people will respond to? Now that therapeutic window is quite nice when there's a large therapeutic window, because we can treat everybody without anybody experiencing a toxic effect. There is another way of comparing or creating a range to look at. And that's having a look, if we look at concentrations, we look at the minimum effective concentration and the minimum toxic concentration. So we can actually create a different range here. This section here, the concentrations here, probably aren't particularly useful because we don't need to get to that level to treat everybody. However, I've drawn the lines in parallel here. However, they don't have to necessarily be in parallel, and they can actually be overlapped. But we can see here that the minimum therapeutic concentration is now much lower, and it actually eats into the original therapeutic window. So in this case, we're starting to see that people might experience that toxic side effect while they're receiving a therapeutic effect. Now, just be aware that a patient who experiences a side effect at this concentration is not necessarily the same person up here. They could be over here. So they could get their therapeutic effect, and it's not until you push the concentration up here that they get their toxic effect. Or they could be up here and up here. So it just depends on the population group and the sensitivity, because they're not always directly linked to each other. And so if we come back to our learning outcomes, so you should be able to explain why patient responses to drugs can vary. It could be because the formulation is different. They may not be taking their medication. They might have genetic or phenotypic variations in their kinetic or pharmacodynamic responses. You should be able to look at how drug safety can be measured. So basically looking at therapeutic windows and therapeutic indexes and looking at how they're different to each other. And you should be able to look at how drugs can have activity without even interacting with a receptor, so the antacids or the osmotic diuretics as examples.